you today on behalf of my colleague, co-presenter and boss, Dr. Ray Fowler. I'm Dr. Ronna Miller, and this is Do No Harm, EMS Care of the Extremely Agitated Patient, an abbreviated version of a longer course, Advanced Mental Health Life Support, which we'll talk about a little bit at the end. So let's get started. First, this is an educational presentation only. Dr. Fowler and I are likely not your medical directors, so please consult with them as well as your own local protocols and guidelines. There will be some off-label mention of the use of ketamine, and neither Dr. Fowler nor I has any commercial or financial disclosures or endorsements to report. Our lofty objectives for this 1 hour we have together are for you to be able to describe the science of the agitated patient, recognize the clinical features of the extremely agitated patient, describe BLS and ALS care principles, identify some of the salient consent, legal, and system oversight considerations, and finally, to value the critical role of EMS collaboration with other stakeholders along the continuum of care. Because of the short time, we won't be able to deep dive into any of the topics you see listed at the bottom, but we'll be happy to come back another day for that. By way of the bottom line up front, I think we all recognize that the extremely agitated patient may be critically ill and poses a potentially grave risk to themselves and to everyone. Safe, humane care must account for medical, traumatic, and psychiatric conditions and the need for multidisciplinary collaboration.
Ron, I would comment here that everybody that's listening today, listen to us. There is a trend in the change of how we evaluate agitated patients in the field. Dr. Miller and I are going to try to deal with the sort of previous assumption that everybody that was crazy was on some kind of methamphetamine-like drug. This is not so. Excited delirium is a term that is going away. And Dr. Miller and I are going to talk about that. Ronna, take it away.
So we're all here to take care of our patients and ourselves and the public and to do the best we can every day that we are on the job. But if you've been following the news for the last couple of years for anything non-COVID related, you know that there have been many high-profile cases in the media and the criminal justice system, the implications of which have bled over significantly and directly into the EMS domain. So I'm going to start with a case. Hopefully the video will work, and even if I think the audio should work as well. I'm only going to show you a little snippet just to set the context for this.
Now, as you're watching and listening, the assumption is that this might be a drug-related thing, but you really don't know. Is this schizophrenia? Is this COVID-induced encephalitis causing delirium? This patient may be critically ill, naked notwithstanding. And so think about what you just saw, Ronna.
Yep. All right. So this condition was actually described well over 100 years ago in the mid-19th century by Dr. Luther Bell, among others, and it was given a number of different names. But even before methamphetamine and crack cocaine came on board, the condition was described in psychiatric patients who exhibited an acute onset of agitation, mania, fever, leading to sudden collapse and death. The interest in this and the reports of this somewhat subsided over the next several decades until about the mid-20th century, when reports began to surface again, often from the psychiatric literature, and the condition was thought to be associated with adverse reactions to the newly developed antipsychotic medications that had come into use, or perhaps to an underlying heart condition. In the 1970s and 80s, with the advent of crack cocaine and methamphetamine, a number of these patients began to show up in EMS and in the ED. And a 1981 case report attempted to explain these deaths in patients that seemed to be somehow linked to cocaine use, although not necessarily overdose. And it was a similar pattern, bizarre, aggressive behavior, often culminating in sudden death. Now, unfortunately, there were a number of social justice and other overlays to this because of the crack cocaine and methamphetamine. And so this term of excited delirium became unjustly associated with and stigmatizing for certain groups in our population. And that somewhat sets the stage for how we got to where we are today. This was largely recognized as an autopsy diagnosis of exclusion, which is an important concept because it means that you had to rule out all the other causes of bizarre extreme behavior to make that determination. And that was often done on an autopsy table. However, in 2009, the American College of Emergency Physicians published a white paper about excited delirium in living patients. And it took on a bit of a life of its own in the ensuing decade or two, where the term became a bit of a lightning rod in many domains, in the media, in the press, in legal concerns, in law enforcement, and it became very high profile and very controversial. It was politicized, there were medical legal issues, there was the use of a medical term by non-medical trained professionals, and then there were all these very many sad and tragic deaths in custody. So in 2020 and 2021, a number of professional organizations that you see here on this slide issued important task force reports or position statements clearly stating that the use of the term excited delirium or excited delirium syndrome should no longer be considered, in part because of the negative historical connotations, and in part, as we'll see in a minute, the fact that there is no established standard medical definition or code or disease associated with this. But they all had in common the recommendation that we should refrain from using that term. Now, unfortunately, around the same time, a number of important publications were under preparation. And in fact, the word excited delirium did creep into a couple of them. Of note, down at the bottom in the draft version of the NAEMSE National Model Guidelines, the term excited delirium was used along with the wording exhaustive mania, but these were fortunately subsequently replaced in the final published version of these guidelines that were just released a couple of weeks ago. Also bleeding into 2021 and 2022, as you probably know, was a state law passed in Colorado, with others being considered elsewhere, to severely restrict the use of certain sedatives, especially ketamine, by first responders. And even more troubling for us were criminal charges that were assessed against EMS professionals involved in at least one of these high-profile cases. All of this had a very dramatic chilling effect on the use of some of these medications, especially ketamine, and generally speaking, on the care of patients experiencing a behavioral health emergency. So there has been a very troubling climate for the last couple of years. So regardless of the name that's chosen, and again, we're trying to avoid using the historical terms, the imprecise terms, the potentially pejorative terms, and many of us are advocating for the use of a much more generic term, that of behavioral health emergency.
And
now,
Ronna, let me interject that we would consider abbreviating that to a BHE.
Right.
So instead of an ED, an excited delirium, it's a BHE. So as you, all of you out there, think about your electronic medical records, what you're going to see is a trend toward a BHE. Ronna?
So what we're talking about here today is patients on this extreme end of the agitation spectrum. We're not talking about garden variety agitated or irritable folks, but we're going to try to stay with the behavioral health emergency terminology. It's not very descriptive, but as we'll see in a minute, we all know it when we see it. So we have all, or many of us have encountered these patients. They're not all that common. I'm now going to turn this over to Dr. Fowler, who's going to talk to you about the science and some of the physiology behind extreme agitation. Dr. Fowler.
Thank you, Ronna. Folks, listen to me, clear your minds, turn off your smartphones, turn off the TV in front of you, listen to me. We've had a crisis in the field all around the world, especially in the United States, where there are patients who have had acute behavioral health emergencies, BHEs, that sadly, unfortunately, have been smothered and killed. Listen to me. If you put somebody face down with a knee in the back, you will kill them. I will explain to you why that's the case. Next slide. There are a lot of reasons why people act nuts in the field. It may be, we'll go around the clock, it may be trauma, a psych problem, it may be drugs. But look at that drugs is only one of many. Environmental factors. You hold them down and they go crazy, that's positioning. You restrain them and they go crazy. Demographic factors, social issues, medical conditions such as encephalitis. I mentioned COVID in the brain. I'm not kidding, folks. Measles in the brain. We don't see much measles anymore, but other conditions that could cause acute brain inflammation, and a person comes in and they act crazy. They have delirium with extreme agitation. Next slide. And so none of these descriptions that we saw before adequately explains the full clinical picture in all patients. Just because they've had a drink does not mean that they're having a withdrawal syndrome and causing delirium. For example, listen to me. Don't assume that when you look at a patient that is acting crazy, that you obviously know what's the problem. These are some of the most difficult patients to assume. Some will talk down, as Ronna will talk about shortly, but some will not. And so thus, what we are talking about, folks, is a stepwise approach to the management of these patients while avoiding things that can hurt them. Next slide. Generally, when you see this crazy person that you just saw on that video, it could be one of generally three things. It could, in fact, be a mental health disorder, actual psychosis, schizophrenia, sociopathic and psychopathic disorders, including a very angry person, acute anxiety reactions. These are all mental health that can cause a delirium BHE picture. Or substance abuse and intoxication. Meth is an upper. A lot of cocaine is an upper. Someone withdrawing from alcohol can be delirious, or it could be something like brain trauma. What did we see? Mental health, substance, and an actual brain condition. Next slide. So what is delirium agitation? It's a state of agitation, aggression, and or acute emotional stress. The patient may or may not be having hallucinations, auditory or visual. If they are having hallucinations, these hallucinations are often terrifying to the patient, and that alone can cause an additional problem with fear. And finally, it can be caused by a combination of pre-existing psych conditions and substance abuse and intoxication. Next slide. Next, thank you. So what are some complications? You also, from having a behavioral health emergency, you can physically get a lot sicker. You can have a stroke. You can have a STEMI. If you don't read EKGs very well, this is a massive acute myocardial anterolateral myocardial infarction. You can become hypoglycemic or hyperthermic. You can break down your muscle cells, causing profound hyperkalemia. This is called rhabdomyolysis, that among other things could cause an acute cardiac arrhythmia and cardiac arrest. Or a person having a BHE can then have a trauma or emergency problem. Next slide. Now, folks, pay attention. You've got to know this, because you've got to know it and you've got to share it with your fellow medical providers. And we have got to get the word out to the law enforcement providers in this nation and around the world, the following material. Listen to me. Ready? Look at the screen. Take a deep breath all the way. Now blow it all the way out. That is called forced vital capacity, FVC. Typically, the typical adult can move about 5 quarts, which is 5 liters of air, of forced vital capacity. Now, folks, listen to this. I'm sorry if you get tired of that, but there's occasional times when you've got to pay attention. Do the forced vital capacity again. Ready? Go. Now ease it out. Half of that motion was due to the diaphragm. The diaphragm goes from the nipple line all the way down to the costal margin, the lower rib margin. That is what's called the excursion of the diaphragm. The movement of the diaphragm moves about 2.5 liters of air, which is about half of your forced vital capacity. The other 50% is moved by the ribs, moving like bucket handles. Listen to me. The bucket handles have to move. If you put somebody prone, let them lie down and don't disturb them, the bucket handles will move fine. We'll come back to that. If you put people on their face and put a knee in their back, you will prevent the bucket handles, the ribs, from moving. The ribs are hinged at the sternum and at the back by the vertebra. You put them face down with the knee in the back, the ribs can't move. You lose 50% of your forced vital capacity. Oxygen levels drop rapidly, and carbon dioxide levels rise rapidly. Within 10 minutes, you are so hypoxic that you lose consciousness. Hypercarbia, elevated carbon dioxide, causes a respiratory acidosis. Thank you, Ronna. Go to the next slide. And so this is the bucket handle motion. For the purpose of this bucket, look at the bucket on the left. This is the rib. It is hinged in the very front. Show the hinge there, Ronna. That is right at the sternum, and then show the hinge in the back. The hinge in the back is by the vertebra. Go to the next slide. I'm sorry, I'm stammering, I'm sorry. And so thus, as Ronna demonstrate then, where the ribs join at the sternal, right there is right by the sternum. And the ribs also have another joint in the back by the vertebra. And in the picture on the right, ladies and gentlemen, the picture on the right is the word you have to know. We have to get it out to your partners and to our law enforcement friends. If those ribs are not allowed to move like bucket handles, you lose half of your air motion. If you do that, you will kill somebody. Ladies and gentlemen, we cannot allow that to happen in the pre-hospital phase, or for that matter, in the hospital on patients today. We can teach citizens CPR and the use of automated defibrillators. We can teach citizens the fact that the bucket handles have to be able to move. Do not, next slide, do not put people prone with a knee in the back. You will prevent air from moving. The diaphragm can still move pretty much, but you lose the rib motion. We have, next slide. So we have to eliminate in our nation, next slide, go ahead and click it. We have to eliminate this. We cannot let this happen again in this nation. Raise your right hand now, all of you. I know it's corny, do it anyway. I will not do this to a patient. I will not let my partner do this to a patient. And if I see law enforcement or others restraining a patient in this manner, I will do everything in my power to prevent this from occurring, because I know this will kill the patient. Next slide. And so we have this thing called restraint asphyxia, or positional asphyxia. There's been studies done. And at the bottom of the thing, you'll see 10%, you had EMS witnessed cardiac arrest, unanticipated. It was preceded, it was preceded by suddenly giving up. Think about that video of George Floyd and that tragedy that occurred there. And all of these folks died. You just raised your right hand and you swore that you're not going to do it. You're not going to let your partner do it, and you're not going to let the cops do it if you can possibly prevent it. So we together as a group of 150 of us today, get the word out to thousands through our website, advancedmentalhealthlifesupport.org, AMHLS.org, that we can get the word out. Next final slide of my section. So the primary goal then is protect the agitated, violent, or combative patients from injuring themselves and protect the public using specific protocols and guidelines. Next slide. Next slide. So the clinical features, what are they? Go ahead, Ron. There really, go ahead and click it. There really is not a code number that really describes behavioral health emergencies. It's not in the mental health statistical book. Next slide. And so there really is, it's a more generally accepted entity in forensic pathology, which is when the patient ends up dead on a pathology slab. Next slide. And so there really is no standard official definition, but we do know that there are some BHE potential features. They tolerate pain, tachypnea, rapid breathing, sweating, diaphoresis, agitation, tactile hyperthermia. They are hot. They won't comply with the police. Folks, they often can't hear, but then they have lack of tiring They don't get tired. We almost call that demonic features 20 years ago. Unusually strong, inappropriately closed, mirror glass attraction. Next slide. And so the practical case, typically focus on this, at least 6 of the 10 are there. Increasing pain tolerance, tachypnea, sweating, agitation, tachycardia, hypothermia, non-compliance, tiring, unusual strength, inappropriate clothing, and mirror glass attraction. Next slide. So what does the typical patient look like? Well, they tend to be young. They tend to be a little larger. Their body mass index, they tend to be a little larger. And most fatalities tend to occur in larger people. Why? Because the chest wall is heavy. In a really big person, the chest wall could weigh 100 pounds. Even if you put them supine, if you've got a chest wall pressing down with 100 pounds, folks, that keeps your ribs from moving. They tend to be male. They tend to be on a sympathomimetic drug like methamphetamine, though by no means always. A uniform feature is they tend to be delirious, which is they cannot hear you. They cannot pay attention. They tend to be hallucinating, and they tend to be agitated and may have bizarre and destructive behavior. Final slide of my section, Ronna. And so the call occurs to law enforcement for a disturbance or agitation or violent assault, and the person, and they are patients, is not responding to authorities or verbal commands. And we have difficulty bargaining or reasoning with them. Listen to me. When you get in the scene of one of these patients, and even when you approach them calmly, hi, I'm paramedic Fowler, and I'm here to help you. What seems to be the problem today? And they are just not hearing you. Be careful. You've got a BHE on your hand. They're likely psychotic. They likely are hallucinating with or without a substance. And so be cautious. Protect yourself, protect others, and protect your patient. They may be overtly psychotic, paranoid, or delusional. Listen, they may not be overtly psychotic. They may not necessarily be wild. They may just be staring, but in the meantime, they're hallucinating audio and visual. And so just because a person is calmer does not mean that they're not having a behavioral health emergency. And finally, you can see a prolonged struggle with law enforcement despite physical restraints. Final question. Look at the slide. What was the thing that determined that a person in restraint was about to die or about to get in serious physical trouble? They get quiet. Please make that a take-home point today. Dr. Miller?
All right. So how do we care for these patients? Well, obviously, everyone's safety is the primary concern. Appropriate PPE should be worn by all responders on scene. And it may be necessary to stage on scene until the scene is safe enough for us to access the patient. However, this must be done expeditiously. As Dr. Fowler pointed out, they are acutely ill, potentially on the verge of cardiac arrest, and we need to get to them to be able to assess them and treat them while at the same time minimizing the amount of time they spend in physical restraint. And you're going to hear about that sort of paradox several times through the rest of the seminar here, because we're trying to balance these somewhat competing needs. It is imperative, however, not to go it alone. A team of 2 is not going to be sufficient to take care of one of these patients. So I'm going to show you a couple of minutes from this video as well. Hold on, let me get out of this. There we go.
Right there. Get on the ground. Sit down, man.
Now this went on for a couple of minutes. I'm going to fast forward, but you can see they keep a safe distance. They don't antagonize. They're waiting to get resources. They don't have tasers. This is an old video, but let's see what happens now. Oops, sorry. Thought I had it there. Hold on. Sorry. Right about here. Okay. All right, this was very dramatic. As you can see, things went from good to not so good, but they did ultimately successfully subdue him without incident and got him onto an EMS gurney and got him into the back of the ambulance for care. He was positioned sitting with the head elevated with no apparent adverse outcome. But okay, we're faced with this patient. How do we exclude all of these underlying conditions? How do we minimize the destructive behavior? How do we maintain responder safety without triggering a cardiac arrest in such a patient? The first important concept is that no one size fits all, and the approach to any individual will need to be tailored to the actual circumstances and resources available. However, there are a couple of basic principles. The first, as you saw in this video, is to resist the urge to antagonize, to use some caution, to be calm, to be calming, to maintain control of our own emotions, perhaps offer some reassurance with the recognition that formal verbal de-escalation is not likely to be effective, and also to bear in mind that in some of these cases, the presence of law enforcement officers, especially a lot of them, may actually aggravate the situation. So physical management, which is the terminology which is now preferred over physical restraint, but we're basically talking the same thing, is somewhat paradoxical. At once, we need to have enough personnel to do this, but at the same time, we want to use the least force necessary for the shortest time necessary, and always being mindful of trying to avoid causing additional injury. Much easier said than done. Various forms of law enforcement restraint are highly controversial, and they're being evaluated now in light of all the recent high-profile cases. But generally speaking, these are, generally speaking, these are becoming frowned upon because we know the danger that they pose to the patient. So sometimes, as you saw in the first video, we just have to get some means of physical management, and it might be in the form of a conducted electrical device. I'm going to say taser just because it's shorter, but I am not in any way endorsing or speaking about any particular brand device. To be clear, this is not a substitute for patient care. This is a tool in an extreme environment to allow us to provide patient care. Now, there is some science associated with these devices. It's a little controversial. Much of it derives from either animal studies or healthy volunteers. But as far as we know, there is not a lot of documented hard evidence to suggest that they cause severe or prolonged effect in humans. But of course, it's very hard to determine that, especially on an individual basis. There is some concern about potential transient metabolic and respiratory effects, but the one that people worry about the most, perhaps, is the cardiac effect and the possibility that these devices could trigger lethal arrhythmias, especially in the setting of a short, what we call dart to heart distance. As a result of that, as you see on this slide, the recommended target area, aside from avoiding the head for obvious reasons, is to avoid the anterior chest in order to keep the dart to heart distance as large as possible. We don't know the direct cause and effect relationship, and it's not always possible to do this, but these are the general recommendations that are used by our law enforcement colleagues. Now, they also can cause local tissue injury, traumatic injury due to a fall. You saw the first guy land on the pavement after he was treated. Rhabdomyolysis, which is a rare condition associated with the devices. And many of these patients end up in the hospital, but the question, of course, arises, is it as a result of the device, or is it because of the underlying conditions or consequences of the syndrome? One thing they do not do is they do not depress mental status. So if your previously agitated patient who has been treated with a conducted electrical device is now altered with a depressed level of consciousness, that is not due to the device, and other causes for altered mental status must be sought and treated. The question about deaths is likewise very controversial. It's hard to prove the chicken and egg association. Many patients who die after being tased had many underlying medical conditions that predispose them to sudden death. So we may never really know for sure whether somebody died as a direct result of the taser or whether it was just an association. One last bit before we go on to more of the patient care, and that is the fact that law enforcement should not recruit EMS professionals to come and remove the taser barbs or probes and then provide medical clearance. That is not appropriate. It will depend to some degree on your local protocols and guidelines. But if we are asked to see a patient to remove a taser barb, they become our patient and we need to assess them. We cannot provide medical clearance to a patient and allow them to remain in sole law enforcement custody. They are now a medical patient. All right, so now that we have some physical management, the next important concept is the idea of the deadly triad. And you'll have to excuse the fact that it says excited delirium syndrome. This was a diagram I had put together some time ago. We'll call it behavioral health emergency. But the first step after obtaining physical management is to control the agitation. And I need to be crystal clear about this. The decision when and how to sedate a patient is solely a medical decision to be made by medical providers in consultation with medical direction. Now, it can be a challenge under these circumstances for obvious reasons, but we have to do the best we can, and it is a medical decision. We want to give the right medication to the right patient for the right time. And in this case, focusing on the far end of the spectrum, we might be looking at ketamine or another option. The 6 or 5 or 7 rights that we use to select any medication for any patient apply here as well, perhaps even more so. And the ideal drug would have a single dose efficacy. It could be delivered intramuscular. It would have an immediate onset and relatively short half-life with no negative cardiorespiratory effects. Let me be clear about this, very important. The purpose of the medication is not to create the term chemical restraint. Just as we should avoid use of the term excited delirium or excited delirium syndrome, we need to refrain from using the terminology chemical restraint. We are providing emergency medication to relieve symptoms and prevent the consequences of this physiologic syndrome so that we can assess, care for, transport our patients and hand them off to the emergency department with a good outcome. So it is to treat symptoms and prevent physiologic consequences, not to restrain them chemically. There are many options available, some of them perhaps more widely so than others, and we don't have time today to deep dive into the pharmacokinetics of all the various drugs you see listed. The choice of the medication, as pointed out in the recently published NAEMSE National Model Guidelines, are based on the usual factors that we use to select any medication. But if you read the wording in this blurb, you recognize right away that that's sort of a best practices scenario. We may not know what their current meds or allergies are. We're going to have to make the best selection we can based on our available resources and training and guidelines. One thing we're never going to do is use this particular combination of drugs, which used to be popular in the emergency department for many years. It's a highly toxic combination with adverse effects. And thankfully, this combination of 3 drugs is not usually widely available in EMS. But even if it were, you should not use it. It is not safe. Whatever drug is selected, we decided that intramuscular is probably the way to go initially. And the intramuscular injection should probably be performed in the thigh for a couple of reasons. The primary one is the pharmacokinetics. The absorption is 7 times faster there than it is in the deltoid. But also you have the option of slightly larger volumes of injection if needed, depending on the drug. And it's okay to inject through clothing if you have to, recognizing that it might take 2 separate injections, perhaps simultaneously by 2 different providers, if the drug volume exceeds the maximum. Now, there have not been very many or really any large, well-controlled randomized trials comparing head-to-head the various sedative agents in the EMS domain. There are several randomized controlled trials from the emergency department, and those references are in your bibliography handout. But in order to really move the science forward in an objective way, we would likely need large, multi-center, well-controlled trials, which are not likely to happen anytime soon. So we're really based on best practices and the knowledge and expertise of our medical directors. But for most of us, the choice is going to boil down to a choice between the benzodiazepines, probably midazolam, and ketamine. And as you can see, based on our needs to have a quick-acting, single-dose, cardiorespiratory stable drug, ketamine seems to fit the bill. But it's a very complicated drug, and we can't deep dive into ketamine today. That's a topic for another seminar. But suffice it to say that dosing of this drug varies widely depending on the route of administration, the indication of administration, the age of the patient, the formulation, and a number of other factors. It's important to point out that use of this for agitation is an off-label use. Ketamine is only officially approved as a general anesthetic and procedural sedation medication. So anything we do in EMS to use this medication to treat a behavioral health emergency is off-label, and there are no absolute dosing standards, although there is accumulating science and experience with the drug over the last 8 or 10 years. And in point of fact, I want to call your attention to this editorial, which was, again, it's in your bibliography. This was in a response to another ketamine report for undifferentiated EMS patients. It wasn't focusing on behavioral health, but the authors point out several important facts. One, we are dealing with emergency circumstances with emergency patients who lack decision-making capacity and the capacity to give informed consent, who are a danger to themselves and others. In other words, this is not the controlled environment of elective surgery in the operating room in the hospital, and we have to work with the conditions under which we operate. And they make a strong case for the safety and efficacy of this drug. And along those same lines, in the recently published NAEMSE position statement, as you can see here, ketamine is recommended as one of several choices as a safe and effective method to protect the violent or combative patient from self-injury. Regardless of the drug, whether it's ketamine or something else, these situations are a setup for adverse drug effects, perhaps even more so than under more controlled circumstances. Some of these conditions are listed here, including the need to sometimes combine medication classes with synergistic effects or adverse drug-drug interactions. An important factor in a number of the high-profile cases has been overdosing due to the inability to accurately estimate the weight of the patient in order to determine the dose, and even circumstances like look-alike packaging where different formulations could be available at different times and could result in a dosing error. So how do we prevent medication errors in the situation of a struggling patient, the need to sedate to evaluate, multiple responders, blood and body fluids, bystanders? The first is to have formal written procedures and policies for medication administration cross-checking. And another strategy is the use of what we call the tactical pause, sort of situational awareness for a couple of seconds to evaluate whether, in fact, we are adhering to the 6 rights and giving the right drug to the right patient correctly. Now that we've done that, we can finally assess the patient. And again, you've heard us say it many times, We cannot assume they are just crazy or just drunk or just intoxicated. We must assume they have a medical or traumatic condition, and we will assess them for those, starting with the least invasive procedures and approach first. In addition to the standard assessment, we're going to add some sort of standard documented scale, either bars or RAS. There are others out there. It's like the opposite end of the Glasgow Coma Scale. These have been pretty well validated for the ED, somewhat less so for EMS, but they are important because they allow us to provide objective documentation both at baseline and during care, and they allow us to communicate effectively in a standardized manner with our colleagues in the ED because they use these same scales. So if we say the patient is a BARS or RAS or whatever, say a RAS 4, the people in the emergency department know what that means because they use the same scale. All right. So what are these medical and traumatic conditions? Well, there are probably 100, and we're not going to have time to deep dive into them today. But as you can see here, some of these are fairly common, and they're conditions that we can assess and treat, and others might have to wait until the patient gets to the emergency department for more sophisticated diagnostic testing and imaging. We also need to remember the time-sensitive life threats that Dr. Fowler mentioned a few moments ago that may develop as a consequence of the syndrome or may have been already present or underlying as part of the process at the very beginning. But we can't forget that these things might be there or might develop because obviously that will have an adverse outcome. All right, so we've done agitation. Now what do? Now we have to cool them off. Tactile and core temperature hyperthermia is almost universal in these patients, probably because of some dysregulation in the brain, which is thought to be one reason why they tend to strip off their clothing. If you have the ability to measure core temperature, that's great. If not, empiric cooling based on tactile hyperthermia is perfectly fine, especially if the ambient temperature is high. And the standard methods of evaporative cooling can be used. Those are things that we're quite familiar with our exertional heat stroke patients, but there are some other adjuncts as well, such as cool IV fluids, ice packs, cooling blankets, and perhaps the TACO or TARP-assisted cooling with oscillation method. This may or may not be feasible in this particular patient population, but we need to cool that brain. We're going to provide trauma care as soon as it's safe to do so, with special attention to some of the specifics that might apply, such as taser injury, the need to remove the barbed darts, falls, TBI, self-inflicted injuries, and the like. Now, let's get back to positioning. We've heard a lot about prone positioning over the last couple of years and how wonderful it is for COVID-19. This is not COVID-19. So to reiterate on everything that Dr. Fowler said several minutes ago, we must never, 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 never do anything that constricts the airway, the neck, or chest wall motion, including anything you see here, or sandwiching the patient under a mattress or a backboard. If you've been on the job long enough, you probably remember seeing this done, and it is mentioned now only to be condemned. The preferred positioning is something more like this: 4 or 5 point restraints with soft restraints, one arm up, one arm down, and preferably elevating the head approximately 30 degrees. Other alternatives may be necessary in the field based on circumstances, and there are physical management devices that are out there, and they afford us the ability to position the patient supine or to tilt them lateral in the case of vomiting. We're going to have to tailor it based on what we have available and based on the individual patient's needs. The modified recovery position is an option, although it has to be used in an appropriate, well-sedated, calm patient. And I would just point out the one important fact that we want the patient to face us in the back of the patient compartment rather than the cabinet, so that we can monitor their airway and assess them on a continuous basis. One other mention for patient comfort: a well-padded gurney is highly recommended. Anything that allows the patient to be a little more comfortable and to struggle a little less is a good thing. Pillows, however, perhaps a little counterintuitively, are generally not recommended because they pose a potential risk for suffocation. I don't know, we could debate on that, but that's the general recommendation. All right, well, what about handcuffs? Handcuffs to the stretcher, handcuffs to the backboard. You know, what can go wrong with any of this, right? It is the general consensus of all the expert groups who have weighed in on this in the last 2 years or so that the least amount of restrictive management is the preferred way to go, with some sort of soft or fabric or strap restraint that can be easily removed or cut off in the setting of an emergency. If handcuffs become necessary, important takeaway point, the law enforcement officer with the key must accompany the patient in the ambulance. Full stop. They don't hand the key off to us because that is a confusion of roles. They don't follow along in their squad car behind the ambulance for obvious reasons. They must ride in the patient compartment with the key. And any patient who gets any form of physical management or physical restraint is entitled to and must receive appropriate pharmacologic sedation to control their symptoms. Physically restraining somebody without sedation is just cruel, and it will precipitate a worsening of the syndrome and likely a cardiac arrest from which you will not be able to resuscitate them. And it's just a basic principle of humane and compassionate care. We need to pay careful attention to the airway for all the reasons that Dr. Fowler mentioned, especially if they have received any form of sedation or physical restraint, watching for the bucket handles, watching the respiratory mechanics. And now we're going to move on to the third aspect of the triad. And that's very simple. It's isotonic crystalloid and vigorous fluid resuscitation with ECG monitoring. If some of the complications such as rhabdomyolysis and hyperkalemia arise and we see worrying trends on the ECG rhythm, we can bolster that with additional interventions, starting with albuterol and glucose and insulin for T-waves that look like the ones on this slide. It's a little bit more controversial to talk about calcium and especially the routine use of bicarb in the EMS domain, but let's focus on the circulation first, which is usually hypovolemic shock, although there may be some cardiogenic component, but vigorous fluid resuscitation. These patients are typically volume depleted and they need to be resuscitated. So what about bicarb? It's a topic for another webinar. Suffice it to say that in 2022, the routine administration, especially of large doses of empiric bicarb in the field, without blood gases, without labs, can be dangerous and it can be fraught with complications. However, if there are EKG changes suggestive of impending arrest, and again, we can't really deep dive on that today, remember, especially for hyperkalemia, that calcium is the first line drug to stabilize the heart, and it can then be followed by bicarb and albuterol and glucose and insulin. But there are complications, and it's possible to overshoot with this in the field where we can't monitor pH and electrolyte values, and that's one of the reasons why we have to be careful. So again, we focus on the dysrhythmias. If they're having ischemia, we treat it. We watch for collapse rhythms and sudden cardiac arrest. And just to fill out the rest of the alphabet, we do all of the benchmarks for all of the scores and all of the important factors we need to monitor. A special attention to the possibility that you might need to redose the patient, either with a second dose of the same medication or sometimes switching to a different medication with all the potential complications that might ensue. But sometimes the sedation wears off before you get to the doc, and you do need to be mindful of that because you may need to redose. Symptomatic hypoglycemia in 2022 should be treated with the standard of care, which is an infusion of 10% dextrose, not the poison of D50. And just to fill out the rest of the alphabet, we will continue to cool the patient to minimize secondary brain injury due to all of the mechanisms listed here. as well as our formal strip and flip to assess for signs of trauma. As you saw in both of these videos, the strip part is actually sometimes already done, but kidding aside, we do need to assess them to make sure they have not injured themselves in the process. Now, if anybody's ever been spit on the job, you know how terrible that is, and you know how it makes you feel, and you're in the back of an ambulance, and this is a potentially dangerous situation. There are commercial products that are available. They need to be selected on the basis of providing full ability to monitor and observe the patient's airway and breathing. And they may be illegal in the emergency department. You may be able to apply it in the field, but the ED personnel may have to remove it. If you don't have one, the old standby is to apply a non-rebreather mask with high flow oxygen, and that is certainly a suitable workaround, all other things being equal. So you're going to identify and care for any of the underlying conditions that may cause or contribute to this. And as Dr. Fowler mentioned, and as I mentioned, beware of the patient who suddenly gives up. There are numerous reports of this in the literature, and people have seen this, where the struggling patient who is resisting despite futility suddenly gets very, very quiet. And that is usually associated with a cardiac arrest from which they are seldom resuscitated. How are you going to transport them? In a ground ambulance. Anybody who does air medical probably knows why these would not be ideal patients for air medical transport. Your destination decision-making will depend on a number of local factors in close consultation with online medical control and the hospital to determine the best destination for this person. En route, of course, you're going to do all the stuff we've already talked about: patient and personnel safety, the ability to monitor and treat, PPE, source control, and importantly, the role of pre-arrival notification and patient reporting. Again, this is the continuum of care for highly unstable, critically ill patients, and we do them a disservice if we are not in real-time communication with our emergency department partners. So the EMS handoff and that communication is absolutely critical to good patient care. What happens in the ER in the first few minutes? They will try to find and finish fixing some of these physiologic abnormalities that we already started to treat. They will then drill down with diagnostic studies and imaging to identify primary diagnoses, as well as to rule out and treat the consequences of the syndrome itself. How many get tubed in the ER? It's hard to say for sure. There have been numerous reports using different pre-hospital sedatives, ketamine, benzos, what have you. There is a bit of a learning curve, and a lot of the initial reports showed a very high rescue intubation rate. But again, some of it is a learning curve, and as experience has been accumulated, that has certainly diminished. So it's hard to say on an individual case-by-case basis. I'm going to turn this over to Dr. Fowler very quickly for the last couple of minutes to touch on some legal and system considerations before we wrap it up.
Thank you,
Dr.
Ronna.
Fowler.
Okay. Can you hear me okay, Ronna? I'm checking to see, can you hear my audio, anybody?
Yes.
Okay, thank you. Next slide. Oh, you got it, okay. State laws vary quite widely from place to place, all the way from the West Coast to the East Coast regarding these laws. Next slide. There's a role of actually a guardian on patients who have mental health disorders. Now, how do you get somebody in to get help? They can come in voluntarily. You can go to a judge, and you can try to get an emergency detention order or an emergency protection order. We call it here in Texas an order of protective custody, which provides for involuntary detention and transport for physician evaluation. Next slide. Mental illness crises involve up to 25% of officer-involved shootings. Law enforcement generally is not equipped or expected to determine capacity or competency of a patient to refuse care. Law enforcement officers also typically lack clinical mental health support. though that is a changing paradigm across the United States, where more emergent social mental health workers are beginning to respond in 911 systems to behavioral health emergencies in the field. And finally, law enforcement officers generally are not equipped or trained to make medical decisions or to provide complex medical care. Next slide. The fatal outcomes, we know they occur in the known mentally ill. The story can be unclear, and on, all the things that you can imagine. The plan was usually for one officer to use a non-lethal force, and then just something began to fall apart on the scene. Next slide. As far as capacity and informed consent, we cannot kidnap people, which means restrain them against their will, but we must have procedures and policies in place that we can determine that patients lack the sufficient capacity to refuse treatment and transport. For example, are they awake and alert at their baseline level of orientation? They're not intoxicated, and so forth. Next slide. We get into the issues of restraint versus refusal. Restraints can never be used to force treatment. Patients deemed lacking in capacity still deserve humane treatment. And finally, we must always balance safety versus the needs of all that are on scene. Next slide. The U.S. Constitution and most all state laws treat the detention and or apprehension of medically ill persons as a civil, not a criminal matter. And so thus use of force or injury against or injury to a mentally ill person will be closely scrutinized in a judicial proceeding, especially now, ladies and gentlemen, in this era. Legal experts advise avoid using force if at all possible. Next slide. Getting help is always helpful. Here in Dallas, we have online medical control 24/7 for the Dallas metro area that allows us to actually get a lawyer involved 24/7 to be able to help manage these patients. Next slide. Protocols are critical, that there are guidelines in place for patient care, for restraint, education, and training and periodic retraining, collaborating with law enforcement, mental health, risk management, legal issues, community, emergency department. And finally, next slide. And the documentation is just like anesthesia monitoring in the OR, in the ICU. Thorough documentation is absolutely critical. Ladies and gentlemen, the era is over. Listen to me. When we can give a sedative to somebody like ketamine or big doses of Versed and then just let the patient lie down and be quiet. If you come to my hospital to get your gallbladder out and we take you to the OR, we're going to have a trained person with you all the time, with you on a monitor, continuous pulse ox, continuous cap note, continuous rhythm strip, vital signs documented Q5 to put you to sleep in a controlled environment. Ladies and gentlemen, what has happened with sedatives in the field is that patients get sedated and then they get ignored. Do not let that happen. I hope that that is clear. We have to get that straightened out. So finally, we have to have performance improvements measures at all times that we can measure the quality of care that we give to our patients, including is there an injury to patients, EMS personnel, and so forth. Next slide. And so it's very important our systems be integrated with the EMS and the hospitals and law enforcement. Next slide. We even suggest statewide quality improvement where these patients actually should be monitored, possibly certainly on a regional basis and possibly on a statewide basis as well. Finally, next slide. We've barely scratched the surface on this. Next slide. That do no harm. Click it, please. Avoid medically legal imprecise terms. Never, ever use prone, hog tie, or hobble positioning. Go ahead. Assume medical illness or trauma until proven otherwise. Next. Use this taser type devices.
Taser if needed.
Yeah, as needed. Go ahead. And Ronna, go ahead and finish the slide.
Yeah. So you may need to use a taser to be able to perform safe initial assessment and to provide care for the deadly triad. Ideal medications for symptom control are fast, short-acting intramuscular injections. Any medical care, including sedation, should be only a medical decision by medical professionals. Any restraint should be humane, judicious, safe, and the least restraint necessary. And patients need to be continuously monitored and frequently reassessed at the same level that we provide for patients in the operating room or ICU. And finally, we need to collaborate with all of our stakeholders across the continuum of care to provide the best possible care for these challenging patients. And then the final thought, which is the fact that everything we do now, more than ever in this era, as Dr. Fowler has pointed out, is under intense scrutiny, but that should not in any way prohibit us from doing the right thing for our patients so that we can provide the best care for them, safety for us, and well-being for the public as a whole. And with that, we will leave you with a link to the handout, which I think is in the chat. And I don't know if we have time for questions. If not, our email addresses are here. Again, I want to thank our NAEMSE organizers and hosts, and I want to thank each and every one of you for attending today.
Yes, and once again, we're sorry to be maybe quite so imperative about some of these things, but there are crisis issues about positioning and about sedation that must be addressed across this nation. I want to thank Dr. Miller for all the leadership she's done in developing this curriculum. Check out www.amhls. Go to the next slide, Ron. Go look at the bottom, amhls.org. Check it out. See what you think. It's a freebie. And we're trying to get the word out, and we would appreciate your thoughts. Thank you all again for attending. Rio, it's all yours. Rio, I think we put you to sleep.
Sorry about that. My screen went down for a second. But thank you both so much for your presentation. There is a few minutes if you'd like to stick around for some Q&A. That would be perfectly fine. Everyone, I put the link in the chat. If you're interested in registering for CE, you can go ahead and click that link. It'll take you to our website. And then as Dr. Miller mentioned, there is the link to the bibliography as well. So thank you all for joining, and we will see you at our next webinar.
Yeah, we'll stick around for a couple of minutes. Dr. Fowler, do you want to take some of these questions?
Oh, I've been answering questions like a crazy person.
Oh, good. Perfect. Well, okay, good.
I've answered dozens already. We just really think that this is a body. I would ask you all just to reflect, is anything we talked about here something that a citizen couldn't learn, or certainly law enforcement couldn't learn? We teach citizens CPR. We teach citizens to use automated external defibrillators. We teach citizens to be able to, draw blood sugars and give EpiPens. So we believe this body of knowledge, especially how air moves through the chest and how we must avoid limiting air movement, is something that can be taught to non-clinical personnel. And so we would hope that we can get the opinion, the fact that y'all would recognize that, number one, we've seen some terrible crises in the field that have been on the front page of newspapers, indeed with law enforcement personnel being convicted of murder. We can avoid this. Let's move over this now generation and move forward in this information era to get this body of knowledge out. Rio, I think we've gone along. We appreciate the attendance of all of you involved. And Ronna, any parting thoughts?
No, again, I just want to thank everybody for what you do every day. Stay safe. Thank Dr. Fowler for his leadership in this. And again, thanks to Rio and our colleagues at NAEMSE for hosting us.
Thank you both so much for the presentation, and thank you all for attending.
Bye-bye. Thanks, everybody. Bye now.